Okay, we are going to get started. So, hello, good afternoon, everyone. My name is Stephanie Verna, and I'm the Research and Program Manager at the Injury Prevention and Research Center in Emory. And so this is our second installment within our data literacy series in collaboration with the Georgia Department of Public Health. And so our first session that we covered was a tool for public health and public policy data analysis called the Online Analytical Statistical Information System, otherwise known as OASIS. But today's session, we're going to move on to our emergency medical services, or EMS, data and going over our trauma data set information. And so here with us today, that's presenting these tools are Ashton Harris and Danlin Lau, who are EMS and trauma epidemiologists at the Division of Health Protection in the Office of EMS and Trauma at the Georgia Department of Public Health. So while they're presenting, if you have any questions, you're more than welcome to put them in the Q&A box, and we'll get to them at the end of both of their presentations. And so let me go ahead and just turn it over to our first presenter, Ashton Harris, as she presents on our EMS data set.
Thank you, Stephanie. Let me go ahead and share my screen with y'all. Okay. Oh, got two screens going. Okay. All right, can everybody see my screen okay?
Yes, ma'am.
Wonderful. So I'm Ashton Harris. I'm the EMS epidemiologist at the Office of EMS and Trauma. I deal with all kinds of EMS data, anything and everything that is under the sun with EMS, I do it. So what we're going to cover today is the purpose of EMS data, some EMS data sources, the data systems that we use, and then I'm going to talk about a couple of examples of how we can use EMS data. So what is it? The majority of our data comes from our electronic patient care records, our EPCRs, and they are collected on each response that's done by an emergency medical service agency. There are certain fields within that EPCR that are required to be completed per our Office of EMS Trauma guidelines. And later on, we'll talk about other fields that are national requirements as well. A great resource that you can see all of the EMS data variables available is the NEMSIS Data Dictionary. And that is the National Emergency Medical Services Information System. And that is what houses the EMS data standard that we all use. I've attached a link for y'all. Later in the presentation, we're going to go through and see an example of what NEMSIS looks like and how you can kind of navigate it a little bit. Currently, Georgia is using version 3.4, but beginning August 1st, we're going to start the transition to version 3.5. So there will be some changes with some elements. So how do we get our data? All of our EMS agencies must submit data as well as have a data management policies. And for EMS agency, that's everybody. So your typical ground ambulances, air ambulances, specialty neonatal ambulances, as well as medical first responders, they have to submit data. And that data is uploaded into our GEMSIS system, our Georgia Emergency Medical Services Information System, within 24 hours after each EMS response is completed. And GEMSIS is where we house all of our EMS records in Georgia. That data is checked against our required state of Georgia fields, and each EPCR record receives a validation score. And these validation rules that the score is based on, they're designed to make sure we get the records properly, they're in the correct format and are accurate, are as complete as possible, and it allows us to ensure validity and accessibility of those records. So I'm going to go over some Common variables in the EPCRs, these are usually completely filled out. As with everything, not all of our data is complete, but we really try to make sure we tell our personnel on the ground, fill it out as much as possible, because that only helps us in the data world. So some examples about what's included in our EPCRs. We have details about the agency and the crew. So as I mentioned before, what kind of service is it? Is it a 911 predominant service? Are they more an air, or do they just do medical transports? What about the crew? What level of EMT are they, or are they a paramedic? As well as dispatch information. So what time did the call come in? What time were that crew dispatched to the call? There's also a whole bunch of timestamps all throughout the record. And that's just, what time did they leave to go to the scene? What time did they leave the scene? What time did they arrive to the scene? And all those can be used for really good measures when you're analyzing data. There's also a lot of information about the incident itself. So where was that incident located? Obviously, we have the address and zip code, but we can also get GPS coordinates of that incident. We look at chief complaint. We also look at primary and secondary impressions of the personnel, medications that were given, the initial patient acuity, the last known well date and time, the type of destination that they're going to. So are they going to the emergency room? Are they going to not an ER? Are they going to a nursing home? And then we can also look specifically at the hospital inpatient destination. And sometimes it's filled out, sometimes it's not, but it can be really useful information. And so we can specifically see in that inpatient, did they go to the ER? Did they go straight to the cath lab? Did they go to imaging? We also look at the exam, vitals, and any scales that were done during patient care. So we have stroke scales and pain scales, but we also collect reperfusion checklists. And there's also information about response and transport. And, there can be a lot going on with this, and it can help you paint the picture of the actuality behind the scenes when you're analyzing that data. So were there any delays? We could have dispatch delays. You could also have response delays. So, was there a lot of traffic? If you're going by air, was weather a problem? Was distance a problem? That's a big problem for a lot of ambulances in our rural areas. Also, why was a certain receiving facility chosen? Was it the closest facility available? Was it a regional specialty center? So a burn center, trauma center, stroke center. So all in all, we have a lot of things we can look at when it comes to data that's in the record. And next, I'm kind of going to go into specific subsets that are available in the data. And these are just groupings that are listed for EPCR data. So we have E-airway, and that can be a variable specific to the placement of an airway when that's done. So we look at indication for placement, and that can be, the airway was compromised, or there was a illness or injury involving the airway that made them choose to place an airway. What device was used is documented. They also document what confirmation method was used to determine that placement. And then, of course, any complications they may have encountered along the way. E-arrest is exactly what it sounds like. It's variable specific to cardiac arrest. So it looks at when that arrest occurred. Was it before EMS arrival or after EMS arrival? What kind of resuscitation attempts were done? So was CPR given before EMS arrival? Was it witnessed, and who witnessed it? Was it witnessed by a family member, a layperson, another healthcare provider, or the EMS crew? Any CPR details that they may have, the first monitored rhythm, if that was available, was there return of spontaneous circulation, and was there AED use? And of course, all of these are important components to look at when we're analyzing data to assess patient care and improvements. So now I'm going to talk about e-injury, because that's a module that also has a lot of good information that we can work with. Most importantly are the cause and mechanism of injury that's documented. So for cause of injury, you may see, was it a motor vehicle crash? Was it due to a fall, an assault? It also documents the mechanism of injury. Was it a blunt? Was it a burn? Was it a penetrating injury? It also documents the trauma center criteria. So why was this considered to be trauma? Was there a crushed, degloved, mangled, or pulseless extremity? An open or depressed skull fracture, a systolic BP of less than 90 millimeters per mercury. Also injury risk factors. So this one is a good one. So was it an auto v pedestrian? Was it a fall of greater than 20 feet? Was it a crash ejection or involving a motorcycle? And then also we have motor vehicle accident details, and that can be, where was that patient in the vehicle itself? Did the airbag deploy, and did any safety equipment, was that used? So like, was a seatbelt used? So this is the visualization of the Nemesis Data Dictionary when you pull it up. To your left, you see a long list of groupings of our elements. And at the very top, you see a legend, and that shows what level the variables are collected at, if they're required, and then how they can be completed. And we're going to talk about that on the next slide. But if it's designated as a state variable, that means the data element is recommended to be collected at the state level. However, if it's a national variable, that means it's required to be collected at the local EMS agency level and then must be submitted to the state. So when you click on a particular element, this is what you see the detailed version of. So we're looking at e-injury.02, which is mechanism of injury. And we're going to talk about usage. So you see, is it right there? It's recommended for use. And the options, it can be mandatory, it can be required, it can be recommended and optional. Really the main difference between those are whether or not it can allow for not values. And so this one is recommended. So it doesn't need to be completed, and it does allow not values. The variable type that is required, it does allow that not value to be documented. There's also whether or not pertinent negatives can be used. And so the way that works is it's documented as an attribute of that element. So for example, for aspirin administration. So aspirin administration is part of agency protocol for chest pain. But say it wasn't responded by it wasn't administered by the responding crew. And that's why it wasn't documented. So say it was given by a family member. That's how you use pertinent negatives. So you would say patient took the aspirin prior to EMS arrival. So they would just document medication already taken, and then they would say aspirin. There's also not values, and that's just saying, it's not applicable, not completed, or not collected by the state. And then is it nillable? That just means it could accept blank, and then recurrence. How many times can it be in the record? So this particular example, it is 0 to many. So it's not required, but it can appear multiple times in that record. So I know I kind of went in a little depth over there, but that's just kind of a basic overview of how to read these particular variables. And all of this information on how to read it is also available at the NMSIS in that data dictionary. So our data systems that we have, I've already mentioned GEMSIS Elite. It's our main data repository. It's a really great resource. And agencies have the ability to see their own data. They can create and run reports. Obviously, as at the state level, we can also create and run reports. And then there's also Biospatial. It's a data visualization tool, and it's really amazing. It kind of paints a better picture with the data and gets you out of the numbers. And it's a really great tool to illustrate what we're looking at. There's lots of different modules available too. You can look at biosurveillance. We see overdose data, pediatric data, transport data. And so it's really a great tool that's available. So another question we think about a lot, we have all this EMS data, but how can we link it to other data sets? Currently, we can link EMS data using a longitudinal ID. So that's a 15-digit alphanumeric code, and it consists of the first 2 letters of the first name, the first 2 letters of the last name, and the last 2 letters of the last name, as well as the date of birth and male or female at the end. So for example, Jimmy Carter was born October 1st, 1924. That is the ID that would be used. And theoretically, you would link it with the EMS record and then, the hospital record, in the trauma registry and across those data sets. Currently, the Office of EMS and Trauma is also working on an armband pilot program, and that's going to be launched within 2 counties, a hospital system, and the law enforcement agencies in that area. Right now, we're only doing crash data because the Governor's Office of Highway Safety is currently funding that project. But each armband will have 6 alpha characters, and they will be entered into the EMS patient care reports, the law enforcement crash record, as well as the hospital's trauma submission. So we kind of link all of those records and get a picture of the patient, as they're receiving care at the crash site with law enforcement, and then all the way through the end of the loop. So how can we use EMS data? I'm going to give an example of 2 projects that I've worked on recently. And the first is interfacility response and transport times for stroke. So what we wanted to look at was how long is it taking EMS to transport individuals from hospital A to hospital B. So that was the start. And we found that it was really a median time of about 20 minutes. And that was surprising because, the hospital end, we're seeing, it seems to take forever, trouble with getting EMS to pick up patients. And then there's frustration, of course, from the EMS end as well. And it's really a systemic problem, but so we were surprised to see that median of 20 minutes. And it took us to the second level of, okay, well, we're seeing the picture at the hospital level. What can we see at the EMS level? So then we looked and did an analysis of how long is it taking from time that the dispatch receives that call to when EMS actually gets to that patient to pick up. And that painted a picture itself too. It wasn't that long of a time. It was within normal reason. And of course, within these data sets, there's always going to be outliers, right? And so now the next project is, we're going to dive into that top 20% or top 10% and say, what's going on with these records? What are the reasons for delays? And just kind of primarily looking through without digging really, really deep yet, we're seeing dispatch delays, but also response delays. I mentioned earlier those types of delays, and right now our EMS workforce is having a little bit of a hard time. And so, that workforce is a problem, but also distance and traffic, and there's just a whole lot of details that go into it. So EMS data can be a great way to address a problem and see what's going on, and then provide data to dig even deeper into what's the root cause and how can we actually collaborate together between hospitals and EMS to put practices in place that can really improve our patient care. And then the second project I've been working on is pediatric response measures. So this was done in rural counties. We wanted to kind of see the landscape of EMS in pediatrics in rural counties. So we looked at how many emergent incidents were there. So how many were emergent to the scene versus emergent away from the scene? And how was the patient transported? Were they actually transported by the unit? How many refused care? How many required transportation to a landing zone? And then also, what's the reason for choosing the patient destination that they wound up at? And of course, closest is going to be most common. It's a huge problem in our rural counties, access to hospitals and care. And of course, closest is going to be the most common reason for choosing that destination. And that's a whole other topic of, level of care versus closest hospital. But of course, family choice is also listed, and then whether or not a regional specialist center was required. So ultimately, we have a lot of data at our disposal, and it can be used to identify areas for improvement for not only us personally, how we can best manage our practices with regards to patient care from our EMS personnel, but how we can improve relationships in hospitals, other healthcare providers, and then using this data to help assist policymakers in making data-driven decisions. So it's really simple to access the EMS data. You just put in a data request to our FIT portal on the Georgia Department of Public Health website, provided a link for you guys, and then email me after you've submitted a request, and I can go through and see what you're looking for, see how I can help tweak it if it needs to be tweaked, and get you going with what you're looking for. And then one thing I'll say before I end the presentation is it's very helpful to kind of look through the data that's available, dive through that NMSIS database to see what we have available as you're looking into creating your research questions and what you might be wanting to find out. Because like I said, there's a lot available, but not everything is required or mandatory to be completed. Of course, us in the data world, we really want it to be complete. We really encourage complete as much as the record as possible, but it's useful to see what we have before you submit that request. So that's my one little tidbit I'll put in there. Thank you so much for listening, and I'll be around for any questions at the end.
Thank you so much, Ashton. That was great. I know that a lot of you have some questions, and that's great. They're coming up in the Q&A, and we'll get to those at the end after our next guest, Danlin, presents her information. So Danlin?
Hello.
Hello.
Okay. Your screen. Can you see the slide? Hello?
Yes, I see the slide with,
Okay.
yes,
That is fine.
not in presentation though. It's not in presentation mode.
Good afternoon, everybody. I'm Danny Noah, and the trauma epidemiologist. I'm from Georgia DPH, and today my topic will be Georgia Trauma Registry data. Here is the outline. First, introduction to the Georgia Trauma Registry, then trauma registry data tables and data elements, and then how to search injury data from Georgia Trauma Registry. And I will give you the example. And then I'll talk about Georgia Trauma Registry 2020 annual report. So the Georgia Trauma Registry is within Office of EMS and Trauma. Vision, a healthy and safe Georgia, exceptional patient outcome through comprehensive, statewide, integrated, data-driven, equitable, and people-centered emergency medical services and a time-sensitive system of care. The mission of Georgia Office of EMS and Trauma is to reduce death and disability by providing regulation, guidance, and leadership to enable the assessment, planning, development, and the promotion of statewide emergency medical services and time-sensitive system of care. So trauma centers in Georgia are designated at different levels to signify available resource and the number of patients admitted yearly. If a facility has both adults and pediatric trauma centers, the designation may differ for each. So right now, there are 32 designated trauma centers. Level 1, there are 4 adult centers, 1 children's center. For level 2, there are 8 adult centers, 1 children's center. And level 3, there are 9 trauma centers. Level 4, there are 9 trauma centers. Also, we have 2 burn centers. It's Joseph Steele Burn Center and the Grady Burn Center. And Augusta University Medical Center is level 1 for adult trauma center, but is level 2 for children trauma center. For all the trauma center information, you can find it in this linkage. The right side is the trauma and specialty care centers map. From this map, you can find where are the trauma centers and what are the levels. Level 1 trauma center is the most comprehensive care center for trauma, capable of providing total care for every aspect of trauma injury. These centers typically serve as a referral resource for the region and usually includes 24-hour in-house critical care coverage by general surgeons and prompt availability of care in specialties. Community leadership in prevention and public education to surrounding communities. Continuing education for trauma team members, as well as organized teaching and research efforts to drive innovation in trauma care. Comprehensive quality assessment program, meeting the minimum requirement for annual volume of severely injured patients. Level 2 trauma center can initiate definitive care for all injured patients and provide similar experienced medical service and resources, but do not typically include the research and the residence components. Requirements include 24-hour immediate coverage by general surgeon, as well as coverage by additional specialties. Tertiary care needs may be referred to level 1 trauma center. Community trauma prevention and continuing education programs for staff. Comprehensive quality assessment program and volume requirements. Trauma registry has the inclusion criteria. Any patient presenting with a traumatic injury occurring within 14 days of initial hospital visit and with an ICD-10 diagnosis code below here. In addition to the list above, trauma patients must include one of the following: admitted to the hospital after discharge from ED, regardless of the length of stay, transferred to or from another acute care facility, died, or died on arrival. Also, we have exclusion criteria. So this is the ICD-10 exclusion code. So our software provider is Digital Innovation and the ESO company. The version is V5. There are about 400 core data elements divided into 33 data tables. Trauma data submitted are de-identified. So online, you can find the Georgia Trauma Registry Data Dictionary. Also, you can find the National Trauma Standard Data Dictionary. Here is the linkage. Here are the 33 data tables. And if you look at here, you'll find that we have airbag deployment, blood product, comorbidity, result, demographic, diagnosis, drug use indicator, ED admission, assessment, drug screen, lab, medication, provider, hospital procedure, if transfer, assessment, if transfer, provider, injury, injury mechanism, organ donated, outcome, patient tracking, pre-hospital assessments, medication, procedure, provider, triage, and protective device, referral, hospital, and the referral assessment. Here, I just give the 3 tables, core element here. The left side is the ED admission table. These are the core elements. You can say there are sign of life, ED, departure date time, facility arrival mode, post-ED disposition, alcohol use indicator, ED arrive date time, activation type, trauma activation date time. Also, you can say OR disposition time in ED and ED CPR. In the middle is the injury table data elements. So we can find the injury country, state, city, county, zip, restraint, injury place, injury ICD-10 place, and occupation industry. And injury date, time, abuse report, and also work related, and cause of the injury type, activity E-code, and alcohol involvement, and chief complaint. The right side is the outcome table, and you can find discharge daytime and hospital days and discharge disposition status, and if transferred for facility ID,
left.
and the primary payer. Then I'm talking about how to search the injury data from the Georgia Trauma Registry. Example, water transport accident injury. How can we find it? So we can look at the ICD-10 E code. So E code V90, 91, 92, 93, and 94. And we can group the data by the first 3 characters. So if we group it, and we'll find these are the frequency and these are the injury detail. If you look at the right side, this is the frequency by year. And here, if we want to look more about the injury, we can group it by the first 4 characters. Look, this is grouped by first 4 characters. And then we can look more about the injury, and there are more detail here. The right side table shows that 61.4 are male patients and 89.1 are white patients, and only 1 is from the work-related injury. Here, the left table shows the injury by age group. We can find that age group 25 to 34 has the highest injury percentage. The right side is the incidence and the case fatality by injury severity score, ISS. So injury severity score range from 1 to 75. The higher the number, the more severe the injury. 1 to 8 is a minor injury. 9 to 15 is a moderate injury. 16 to 24 is severe injury. Bigger than 24, it is very severe injury. We can find that the minor injury is 50.5%, and the moderate injury is 30. Injury. Very severe injury have the highest case fatality rate, it's 12.5%. Here shows the injury quantity and the frequency. We can find the high frequency happens in this highlight injury county: Cherokee, Battle, Hall, Gwinnett, Chatham. Then I'm talking about the Georgia Trauma Registry 2020 annual report. This report is very long. It's more than 70 pages. I cannot talk all of them. If you are interested, you can look at it in our website. And today, I only talk a partial of it. So for 2020, there are 31 trauma centers. For level 1, there are 6. Level 2, there are 9. Level 3, there are 8. Level 4, there are 8. So the right side is the trauma and the specialty care centers in the 2020 map. From this map, you can find the trauma centers and their level and find where they are located. This figure shows the incidence number and percent by facility level. The majority of the trauma patients were treated in level 1 and level 2 trauma percentages. Look, level 1, 51.7%, and level 2 is 37%. This table shows the frequency of patients by the location the patient arrived from and by ISS. So this line shows the patient came directly from the scene. So we can find 65.5% of the trauma patients, they came directly from the scene. Here, the second row is patients came from referring hospital. We find that 22.9% patients came from referring hospital. For the patients came directly from the scene, we can calculate it all the time. So the left table is the median time from EMS dispatch to EMS scene arrival. We can find it is 9 minutes. The right table shows the median time from EMS scene arrival time to EMS scene departure time. So EMS stay on the scene for 18 minutes. This left table shows median time from EMS scene departure time to hospital ED arrival time. It takes about 24 minutes. And this right table shows the total time. That is the median total time from EMS dispatch time until the hospital ED arrive time. It takes about 53 minutes. This figure shows the trauma incidents by age. So we can look at here, there are peak, and the highest number of trauma incidents is between 18 to 32 years of age. The right figure is the incidence by age and gender. The red is male and the black is female. So we can find here is the 71 years. Okay, so we can find male patients younger than 71 years of age had a higher number of trauma than female. However, female patients 71 years and older had a higher number than male. This figure shows the incidence by selected mechanism of injury and age. The red shows the fall injury. The black shows the motor vehicle traffic injury. The gray shows the firearm injury. And from this figure, we can find that number of fall injury are higher than motor vehicle injury in patients less than 15 years of age and those who are 54 years of age and older. This table shows case fatality rates by age group and gender. And the master column is the male, and this one is the female. So male case fatality rate 5.2% is higher than female case fatality rate 3.1%. The left table shows the primary payment source. So we can find the most frequent primary payer is Medicare. It's about 26.9%. The right table shows the incidence by mechanism of injury. So the most frequent type of traumatic injury is fall, followed by motor vehicle traffic and firearm injury. Among the top 3 injuries, firearm injury has the highest case fatality rate, 15.5%. The left figure, you can see the percentage of incidence by selected mechanism of injury and the gender. Look at here, this is the fall injury, and the red is the female. And you can find that the percent of force-related injury in female is higher than that in male. Here is the firearm injury. The percent of firearm-related injury in male is higher than that in female. The right figure shows case fatality rates by selected mechanism of injury. Look at here, this is a firearm. So you can find firearm-related injury had the highest case fatality rate for both female and male. The left table shows the incidence and case fatality by injury severity score. And the minor injury and the moderate injury account for 83.7% of all the traumatic injury. The right figure shows that the trauma patient with very severe injury has the highest case fatality rate, 42.3%. This figure shows the incidence by injury severity score and age. So the dark red is minor injury, and the bright red is the moderate injury. We can find the minor injury and the moderate injury are the majority injury. The table here shows the incidence and case fatality rate by intent. And we can find that 86.5% of the injury are unintentional injury. 10.7% are assault. The right figure shows that the self-inflicted case fatality rate is the highest. It's 24.9%. Here, the left table shows the median length of stay in days by selected mechanism of injury. If you look at the top, that is fall injury. The median length of stay in hospital is 4 days. The right side shows the severe the injury, the patient stay in hospital longer. Look at it. The left side shows the median ventilator days by mechanism of injury. If you look at here, you'll find that firearm, the median ventilator days is 2 days. And here shows the median ventilator days by injury severity score. You can say the more severe, and the patient use the ventilator longer. And the right side is the median ICU days by selective mechanism of injury. So if you look at here, it's 4 injury, and the medium ICU days is 3 days. Also from here, you can say that the more severe patients, the longer the patient stays in the ICU. Here is the incidence by ED discharge disposition. From this table, you can see that 45.5% patients, the discharge disposition is to go to the floor bed. And also you can find that 1.7% of the patients died in ED. That is representing 618 lives lost. The right table is the frequency and the percent of hospital discharge disposition. So from the top, you can say that 57% patients discharged home with no home services. Also, you can find that 3.3% of patients died. That is cost 1,179 life lost. The left side is the trauma program address, and the right side is the information for contact. And if you are interested, you can look at the Georgia Trauma Annual Report 2020 online. And also, if you want to get the trauma data, you can apply through the DPH data request portal, PHIP portal on the Georgia DPH website. Thank you. And if you have any question, you can ask.
Thank you so much, Danlin. I appreciate it. And so I think we have quite a few questions. So we're going to get to those. If you would. Okay. All right. So a couple of things is thank you for attending as well. And so getting to our first question, we have, and I believe this might be for Ashton specifically, doing with like the data linkage. So will there be linkage to trauma registry data via the NEMSIS unique user ID once NEMSIS version 3.5 is implemented for the next version?
So there is linkage, but the problem with that is it's an optional variable. So really what we're working on is more of like what I mentioned with the armband project, linkage across all of those fronts. But Georgia specifically, we don't have a validation rule requiring that unique identifier be filled out, and we're not going to have one. So as far as our rules go for version 3.5, no, that's not going to be required. So as far as linkage goes, it's kind of a mixed bag. It's available, but only if it's being used.
Okay. Thank you so much for that answer. I appreciate it.
You're welcome.
So our next question is for unknown patients. So for example, someone that you found like unconscious, you don't have their like initials or their date of birth. And so how are those patients ID'd like in the record, and can those records be linked like by other means?
So a lot of the times it's blank, unfortunately, but also, we'll have our typical Jane Doe, John Doe, that kind of thing. They can actually go back and update the record. So, just kind of like in my data experience using it, the real problem is if they're just by themselves and found, because if they're with, family members or someone who knows them, or they have ID on them, the initial EPCR that you'll see is missing that information, or it's not completely correct. And then you'll go back and see the more complete, the record that has been completed all the way throughout, that'll have that more to date information. And then as far as linkage, that's a hard one. Really it kind of depends on information that you have, so if you don't have a dependable name, but you have a date of birth, you can kind of work with the registries on hand and see what you have that matches. Obviously that takes more collaboration between the two, trying to get confirmation on this patient, I guess you could say.
Okay, absolutely. Thank you so much. And so the next question, we have about time for, I think, like 2 or 3 more questions. So does EMS data, or does EMS have signal data? So for example, like an ECG?
Yes, if an ECG was documented, that is in the record. And it's represented differently. So values can be listed as a variable, but if you actually open up the EPCR, you can see sometimes the image of the readings.
Okay.
And of course, it's going to be agency dependent. Not everybody documents the same.
Sure. Okay. And one another question that we have is, are private EMS agencies, are they able to refuse giving out certain data sets, such as their response times, the time that it was dispatched, reason for delays, etc.?
So all of the data that we receive at the state is state data. So obviously, they're submitting it to us. We receive everything, whether it's a private agency or a public agency. As far as refusing to send out that information, I don't think they can, because, at this point we house the data, but obviously, we're not going to give out data that's identifiable. So we're not going to say, oh, this particular agency has this problem with response times. So in that response, it's kind of a moot point, really, with the data that's given out.
Right. Okay. And so hopefully at this moment you can see me sharing the QR code with our let's see, with our survey for the actual end, so that we have just some data on like how you guys liked it or what you want to see in the future. But I would like to thank our guests, Ashton and Danlin, for presenting on the EMS and trauma data sets for us. And so again, this is being recorded, and we also will be sending out a link with the different resources to the presentations as soon as we can get everything cleared and uploaded. So I just wanted to thank you for attending today. And like I said, after you get out of this, there should be a link for a survey. There's also one that I dropped into the chat, as long as you can also take a picture of the QR code that will take you to our survey. It is only 5 questions. And we do appreciate you joining us today. So again, I just want to say thank you so much to our DPH, our friends at DPH, our epidemiologists. And I hope you all have a great day, and come hang out with us. In 2 weeks, we have our other data sets that we'll be presenting on March 8th and March 22nd. So you are more than welcome to register for those as well. Thanks so much, everybody. Have a great day.